class. This chapter is extremely important because it provides you the very important information regarding these acute and chronic respiratory disorders, namely asthma, COPD, and bronchitis. Okay, these are the patients that are going to be admitted to the hospital because obviously they're going to be in some type of respiratory distress, so they're going to come in either through a doctor's office or through the emergency room, and in order to better oxygenate these patients and do frequent lab testing, diagnostic testing, we're going to have to admit them as patients. So it's very important as a nurse that you understand the pathology that goes with each of these diseases and look at the patient as an individual, because just because you might have 2 or 3 patients on a unit that have COPD, each one may present very differently. So the key to helping these patients and to better assess the interventions that we provide for these patients to see if they're better oxygenating is to just really watch them continuously and see how they respond, because everybody's going to respond differently, and that's to some of our nursing interventions as well as some of the medications that we're going to give our patients. And that's a lot of the treatment for these patients with COPD and asthma is the medications. And we've really got to really understand how they all work, what kind of potential side effects we could see from them, and just kind of determine if this is the best plan of treatment for these patients who come in with these respiratory problems. So let's move on and talk about this word that we use to kind of describe this category of respiratory diseases, chronic airflow limitation, and it includes the chronic lung diseases such as asthma, chronic bronchitis, pulmonary emphysema, and the thing that's important to understand too is emphysema and chronic bronchitis, and many times patients will have kind of both of these together, and these are termed COPD or chronic obstructive pulmonary disease, and that one word obstructive is very important because that kind of defines, you know, what COPD is all about, obstruction, okay? So we want to look at those pretty much together and see how they manifest. And what's also important to know is what's the pathology behind emphysema, chronic bronchitis, as opposed to asthma. What's the difference? And that's what I hope that you get out of this lecture and from your reading, that you really understand. And again, it's so important, and I can't stress enough, that you go back and you look at the normal anatomy and physiology of the respiratory system, especially looking at the structures in the lungs. When we talk about airways, what does that mean? That means bronchioles. What happens in the alveoli? Things like that, because then it helps you to so much better understand the pathology behind these respiratory problems. And as I said before, COPD includes emphysema, chronic bronchitis, very much characterized by bronchospasm and dyspnea. So what do we mean by bronchospasms? We're talking about the bronchioles, okay? Those are tube-like airways, okay? That's how the air passes through to reach the alveoli, where we have the diffusion and exchange of gases. So what happens with these diseases, when they go in some type of what we call an exacerbation, those bronchioles start to spasm, and when they spasm, they constrict. So we're talking about a bronchiole that now is much smaller in lumen size, so we have a more difficult way of that air getting to those alveoli, and with that we have dyspnea. Now again, remember when we talked about the assessment of the respiratory system, we want to see to what degree the dyspnea is occurring. You know, are they extremely dyspneic? Are they just dyspneic with activity? So that's also a very important part of the assessment. And remember, this also is very important, is tissue damage is not reversible and increases in severity, eventually leading to respiratory failure. And when we get these patients in the hospital, it's very, very important to look at their history, okay, because there's always a reason why someone becomes diagnosed with COPD. And the most frequent reason is obviously smoking. But we kind of look at the nature of how their disease has presented with them. How often have they been a patient in the hospital? We have to also think about the disease process, that this is not something that gets bad overnight. It progressively gets worse over time. And that's why eventually these patients will have respiratory failure. And we'll get into more details and specifically to why that occurs. Because even though some of these patients are diagnosed with COPD due to smoking, some of these people still do not stop smoking. That's how serious their addiction to that tobacco is. And that also kind of causes them to have more progression of their disease, causing them eventually to lead to respiratory failure. Okay? And before we get started about talking about asthma, I just wanted to tell you that there's a lot of people in this country that have some type of this chronic airflow limitation diseases, about 40 million people. And as I said before, just to kind of iterate that COPD and bronchitis are not reversible. It increases in severity, eventually leading to respiratory failure. Asthma is more of an intermittent disease with reversible airflow obstruction, very much characterized by wheezing. But whatever the respiratory problem is, the goal for both of these is to maintain and receive adequate oxygenation and tissue perfusion and try to relieve some of the respiratory distress that comes with it, okay? So these are very, very serious situations, and we don't want to take it lightly, okay? And we want to understand each person's specific way of how they present with their particular respiratory problem. Because like I said, not all people or not all patients are going to present the same way with their asthma or with their COPD or bronchitis. Okay? So let's really talk about these disease processes more specifically and kind of understand more about their pathology, more about what really is occurring, and what kind of manifestations I would see with these patients when they come into the hospital. Asthma can occur at any age, okay, and usually about half the adults that have asthma have it as a child. And asthma can be diagnosed and classified on the basis of the frequency and severity of the manifestations and even the person's response to drugs. We kind of look at their history. You know, when a patient comes in with an acute bout of their asthma, we kind of ask them about their history. What's your patterns of dyspnea? Did you have chest tightness? Did you cough a lot? Did you wheeze? What kind of mucus production? Usually we see an increase in mucus production. And we kind of look at how and when that particular attack occurred. Many times people, you know, will get a cold or get some kind of upper respiratory infection, and wow, all of a sudden they have an acute exacerbation of their asthma. Or others can develop an attack due to some kind of allergy that they have. And then there's many people out there who really know what triggers an attack. They take their medications very faithfully. They understand how these medications work, and they can go for months at a time without having any signs and symptoms of any asthma attacks or any signs and symptoms of any respiratory distress. You could look at a crowd of people and not know which person has asthma if they're very well controlled. Now, sometimes people that have very progressive COPD, you can pick those people out in a crowd, but not necessarily someone who has asthma, okay? So let's look at asthma. It is a reversible airflow obstruction and characterized very much by wheezing. And we know that the wheezing is caused by, as that bronchiole starts to narrow, that lumen starts to get smaller and smaller. Wheezing is that passage of air trying to get through that small lumen. You know, think about if you blow air through a straw. Sometimes you get kind of a weird sound. Well, that's where the wheezing comes from when you listen to the patient's lungs. And sometimes this wheezing can be so loud that we don't even need a stethoscope. We can hear it right next to the patient. We can hear audible wheezing, you know, without even using a stethoscope. Now, this only affects the airways. Please, when we talk about airways, we're talking about the bronchioles. So it does not affect the alveoli. But this obstruction can occur in two. And just to talk about these two types of conditions that occur are the inflammation and the airway hyperresponsiveness. And as I said before, both problems can occur at the same time. And I just want to also say that even though we have better medications and have better ways in which we can help people control their asthma, not having as many attacks, it still is a very serious respiratory disease. And there are still people dying every year from the severe obstruction that it can occur. And we're still seeing more than 5,000 deaths from acute asthma in the United States. And it would even be interesting to look up on the CDC and see how many, currently are dying from asthma. So we can't take the disease lightly and realize that we want to prepare the person to have a better control of their disease and to understand their medications, to not get themselves in a situation where they can have severe distress leading to probable death. This is just a great picture that shows, and I'm going to bring it down so you can see it in the full screen, a picture of the anatomy and the structures in the respiratory system in the lungs. And as you can see, the alveoli kind of look like the grape-like structures, and then we have the bronchioles. And as you can see, there's like a cross-section picture which shows how much those bronchioles start to constrict, causing spasms, contraction. With that, the goblet cells continue to produce mucus, and you can see how swollen the mucous membranes get to be. You have hypertrophy of the smooth muscle, and all this mucus production begins to happen. And you can see how narrow that lumen in the bronchioles begins to occur. And this is where you get the wheezing and your patient's having some sort of degree of dyspnea. And remember, as I said before, bronchial asthma is an intermittent and reversible airflow obstruction affecting only the airways and not the alveoli. Airway obstruction occurs by inflammation and airway hyperresponsiveness. And asthma can be classified into different types based on the triggering events. Inflammation can occur in response to specific allergens. You know, if someone's allergic to something that's in food, like a preservative, maybe that could trigger an asthma attack. General irritants, maybe a certain soap or, some kind of powdery substance, a microorganism, or even a medication can cause an asthma and trigger an attack. And hyperresponsiveness can occur with exercise, upper respiratory infection, or sometimes we don't always know the reason why that particular response is occurring. And with some of our patients who do have asthma, sometimes we see symptoms happen seasonally. Maybe sometimes certain activities, as I said, exposures, or sometimes it happens more at night for the person. or it can be associated, as I said before, with a allergic type response. And many times with that, we might see the patient develop other manifestations with their allergic asthma attack. And with that, they may also have rhinitis, maybe a runny nose, a skin rash, itchy skin, and these are things that you definitely want to assess in regards to how do they present with their particular type of asthma. And remember, some of the manifestations that we see are, of course, shortness of breath, audible wheezes, increased respiratory rate. Think about it. They're trying to get more air in. Wheezes may be louder on exhalation. And with that increased inflammation that's occurring in the bronchioles can result into a lot of coughing. With severe distress, you may see a person use a lot of their accessory muscles. And, you know, I've seen some children that because of the severity of their attack really have a lot of muscle retraction at the sternum. And this really indicates that a person is in severe distress. Along with the wheezing, the breathing cycle is longer and can require much more of an effort to breathe. And you've seen people before that have had asthma attacks where they really are so short of breath that they can't even talk. You know, that's why, again, assessing their respiratory effort, because along with those types of symptoms, you may see people really develop some serious signs of hypoxemia, where their oral mucosa and their narrow beds become cyanotic. We're going to see also changes in pulse ox that will start to drop. This is going to have a profound effect on the cardiac system, where they would become extremely tachycardic, and we might also see changes in level of consciousness. Okay, there are some labs that we can do to help determine the type of asthma and the degree of breathing impairment, okay? And probably along with blood work, these patients who come in severe distress, as I talked about earlier, when they have severe muscle retraction, this can lead to a problem called status asthmaticus, and we'll talk about that. That's more of an emergency type situation. And we're going to see ABGs drawn to look at the status of their you know, pH and how hypoxemic they are, and that kind of stuff. So with asthma, you might want to also consider genetic origin, where there may be a genetic variation in the gene that controls the synthesis and activity of the beta-adrenergic receptors that impact drug therapy. A lot of times with allergic type asthma, it might be caused by allergen binding to the immunoglobulin E or the IgE. And remember, those bronchospasms can occur as a result of that airway hyperresponsiveness. And like I said before, sometimes medications can actually trigger an asthma attack in some people. You know, you think these drugs are safe because they can be bought over the counter, but as aspirin and other NSAIDs can really cause someone to develop an asthma attack. And that's why initially when people are diagnosed with asthma, it might take them a while to kind of feel for what is it that really triggers me to present with an attack. And sometimes it can be just basic stress. And those might be conditions in which someone may develop some type of asthmatic attack. And with older adults, they can have the change in sensitivity of beta-adrenergic receptors. And our goal as healthcare people, along with the healthcare provider, is to really teach our patients how to prevent asthma attacks and what to do, and really to understand their medications, okay? Asthma is much more prevalent in women, about a 35% higher incidence in women than men, and we want to really teach them the correct use of preventative and rescue drugs, especially their inhalers, and how to use those inhalers properly. So as we look at the management of asthma, of course, learning about their history, learning when they were first diagnosed, making those physical assessments and clinical manifestations. And these are some of the things that we may assess with these patients. Audible wheezes, increased respiratory rate. Wheezes louder on exhalation, increased cough. Use of accessory muscles. Now when we talk about barrel chest, this isn't something we see very often in asthma. Severe asthma may have a barrel chest. Those are people that have had a long-standing, very uncontrolled asthma. But for the most part, we don't really see barrel chest with asthma because it is a reversible type of respiratory disease. We see barrel chest more associated with our patients with emphysema. But they do have a long breathing cycle which requires more effort. In those late stages of the attack, cyanosis, hypoxemia, may include changes in the level of cognition or consciousness and tachycardia. And that's because these patients are not being oxygenated well. So we're going to see the effects. And when our brains don't get enough oxygen, we start to see those changes in the level of consciousness. These are some of the labs that you may see done. Obviously, ABGs, arterial oxygenation level may decrease in acute asthma attacks. Makes sense. That lumen, bronchial spasms, we're not getting enough air in, so there's not that air getting to that alveoli for proper oxygenation and gas exchange. Arterial carbon dioxide levels may decrease early in the attack and increase later, indicating poor gas exchange. And I want to really kind of focus on that for just a few minutes. Why does that happen? Because when a person initially begins to have an asthma attack, what do they start to do? They start to breathe very, very fast. So with that fast respiratory rate, they're blowing off carbon dioxide. So that's why their CO2 levels start to fall. But then they start to increase later because guess what? If there's nothing to intervene this attack, the attack continues to progress, and what happens is people start to get tired. So as that attack continues, then the person really starts to slow down their respiratory rate, thus not blowing off as much CO2, thus holding on to that CO2, and that's why you see that change in arterial carbon dioxide. And then what else we can see is allergic asthma with elevated serum eosinophil count and immunoglobulin E levels. And that's many times how we can diagnose it as more of an allergic asthma, because you'll see those serum eosinophil counts increase. And the sputum itself may contain those eosinophils and mucus plugs that shed this epithelial cells, and those are called Kirschmann spirals. So please remember that, Kirschmann spirals, C-U-R-S-C-H-M-A-N-N spirals, and we'll see that as evidenced in their sputum. So that also makes a diagnosis of more of an allergic type of asthma. And the most accurate measure for asthma are pulmonary function tests using spirometry, including forced vital capacity, forced expiratory volume, and peak expiratory flow rate. And I wouldn't expect you to know all the components of pulmonary function test, but this is a huge test to really determine and make that diagnosis of asthma, and then later on done to progressively see if that asthma is getting any worse and maybe more aggressive treatment and therapy for that patient. Other diagnostic assessments are chest x-rays, because we want to make sure that the dyspnea is being caused by the asthma and not maybe some cardiac issue. So again, we know the importance and relevance of a chest x-ray, how much we can see on that chest x-ray, and along with looking at lung structures and looking at possible signs of atelectasis or changes in respiratory and cardiac structures, we're going to do repeated chest x-rays. If the patients are on any kind of theophylline or methylxanthine, and we're going to get into the medications very soon, if you take down their history and get a list of what medications they've been on, and they've been on Theophylline might be very important to get a theophylline level to see if they're in therapeutic range, or maybe not taking enough, or maybe you also want to additionally assess with your patient. Education is probably one of the most important aspects of asthma control and treatment. Patients need to be in control and understand their disease process very well, learning about what is my particular way of how I demonstrate asthma. Patients can co-manage this disease, increasing symptom-free periods and decreasing the number and severity of attacks. And we're going to talk about peak flow meters, should be used twice daily by the patient along with a personal drug therapy plan. When we talk about patients and peak flow meters, what we mean by that is we want our patients with asthma to do kind of a self-assessment on themselves, establish a baseline of peak and expiratory flows. And what we'd like to do is have them do it 2 times every day for about 2 to 3 weeks. And it looks like an inhaler. And what they do is they set that peak flow meter at 0. And they usually stand when they're doing this test. They take a deep breath as they can, lips tightly around it, and they blow out hard and fast. And what they want to obtain from this test is different colors. And green means everything's good. They're being well controlled. Yellow means they might need more of a rescue drug, maybe want to assess their drugs that they're on or their medications to control their asthma. If it's in the red zone, which probably would be also demonstrated by symptoms of distress, the red zone would indicate that maybe the patient is heading for an emergency. So that's what we want to really stress to our patients, that they need to do this for themselves to make sure that they're on the right meds and that they're in good control of their asthma. Okay. You have to understand that when people start to have attacks, this really can be very disruptive in one's life, because when you can't breathe, it will affect your work, it will affect your school. It really affects basically quality of life. Allergy is probably one of the strongest predisposing factors for asthma. Irritants or allergens that increase the risk of people developing some type of asthma attack. And some of those allergens, as I talked about before, may be more seasonal. Maybe they experience more attacks in the spring when there's more grass, trees, weed, and pollens. Also, other irritants that can trigger are even air pollutants, cold or heat, or there's significant weather changes. Even people might be very sensitive to strong odors such as perfumes or even smoke if you're around someone who smokes. As I said before, exercise stress, being emotionally upset can trigger an asthma attack. And remember, there is that diffuse airway inflammation that leads to obstruction due to those following factors, where you have swelling of the membranes that line the airways, mucosal edema, so that decreases the airway diameter, and you have contraction of the bronchial smooth muscles that encircles the airways. And that's what causes that bronchospasm that further narrows that bronchial. And then, of course, the increased mucus production, which also diminishes airway size and may entirely plug the bronchi. And sometimes those secretions get so terrible that they become obstruction within themselves. The bronchial muscles and mucus glands enlarge. You have thick, tenacious sputum is produced, and sometimes you can even have alveoli hyperinflation. And remember, think about what causes that inflammatory process. They're cells that play a key role in the inflammation of asthma. When we talk about mast cells, they release those mediators, and those are chemicals such as histamine, bradykinin, prostaglandins, and leukotrienes that perpetuate the inflammatory response. They cause increased blood flow, vasoconstriction, fluid leak from the vasculature, and the attraction of white blood cells to the area and cause bronchial constriction. So I just kind of wanted to remind you about how that inflammatory process occurs, because when we talk about the meds, it'll make sense why these are being prescribed, okay? And remember, in the bronchiole, there are alpha beta 2 adrenergic receptors of the sympathetic nervous system, and then when these are stimulated, that's when you also have bronchial constriction occurred, okay? And that'll make sense of why we give those medications to counteract that bronchial constriction. When we give beta 2 adrenergics to stimulate bronchial dilatation, okay? So just wanted to kind of go over that again so that refreshed your memory, gave you the foundation of how the inflammatory process occurs and why the medications we give are so necessary for our patients that have asthma. And of course, I can't stress the importance of how drug therapy plays a huge role. Pharmacologic management is based on the STEP category for severity and treatment. Preventative therapy drugs used to change the airway responsiveness to prevent asthma attacks, and again, to teach our patients that they're to be used every day regardless of symptoms, not just when you're having an asthma attack. But there are difference between rescue drugs and the long-term drugs that we used. The rescue drugs are used to actually stop an attack once it's started, and that's the only one that we encourage our patients to use, because that's the only one that's going to have any effect when our patients go into an acute exacerbation of their asthma. And before we start the medication, I just kind of want to sum it up that in regards to asthma management, a person has to know, what is that trigger. So they need to avoid potential environmental asthma triggers such as smoke, dust, mold, and even weather changes. Avoid meds that may trigger an attack, aspirin, NSAIDs, even some of your cardiac meds like beta blockers. Avoid foods with MSGs. With exercise. Sometimes if that's to trigger an asthma attack, it might be advised that a patient use some kind of inhaler that provides that bronchial dilatation to the bronchioles, and we would encourage a person to use that about 30 minutes before exercise to prevent or reduce bronchospasms. And the proper technique and correct sequence when using metered doses, get enough sleep, reduce stress, and to, of course, check that peak expiratory flow 2 times a day. That would indicate signs of respiratory distress. So these are things that we definitely want to teach our patients, and in those regards we can hopefully keep our patients very free of an asthma attack and prevent them from getting into a situation which could be a life-threatening situation with severe respiratory distress. Okay, let's now go over this medication list, the drug therapy that we'd use for our patients. And not only as nurses do we need to understand how these work, because we are the ones that provide the education about these meds for our patients so that they too understand exactly how these medications work and how they can keep them pretty free from an exacerbation, and if one does occur, what they can do immediately to prevent it from getting worse. Okay, the first group of medications are bronchodilators, and these all work by increasing bronchial smooth muscle relaxation. So what is going to basically happen is we're going to have an opening up of these airways, okay? And we can look at 2 types. Our short-acting beta-2 agonist and our long-acting beta-2 agonist, okay? And the only one that we would advise or strongly encourage our patients to use if they're having a asthma attack is a short-acting beta-2 agonist, okay? These are fast-acting rescue drugs, okay? And one other bit of important information is that people need to keep them with themselves at all times, okay? And again, this is an inhaler type medication, so we want to make sure that our patients are correctly using them. Maybe it's great to have them demonstrate their technique, because we don't want the medication escaping through their nose. And if they're on other types of inhaled drugs or medications, we want them to use that 5 minutes before other inhaled drugs, okay? Bronchodilators work very well, but we can see some kind of adverse reactions. And what can happen with these is we can see our patients really develop a very high heart rate, become very, very jittery, and maybe do not tolerate the short-acting beta-2 agonist, very well, okay? But it's important to know that the short-acting beta-2 agonists are actually can stop an attack once it's started, okay? The types of inhalers that may be used with these drugs are either your MDI or your DPI, and what those stand for is your metered drug inhaler or your dry powdered inhaler, okay? And an example of this type of medication is Proventil, Xopenex. Usually a person would use 1 or 2 inhalations every 4 to 6 hours, okay? And again, one of the most common side effects with these is heart rate can really increase. This might also be used for an activity that might also, cause a person to develop a asthma attack. Maybe they might use this before they eat. Maybe they might use this 30 minutes before they exercise. Something that would trigger an asthma attack, okay? So that's short-acting beta-2 agonist, okay? And what they do is they actually bind to the beta-2 adrenergic receptors and cause an increase in the intracellular levels of that substance called C-AMP, which is a cyclic adenosine monophosphate, and this substance will trigger that smooth muscle relaxation, okay? And the good thing about this is that medication is really quickly delivered to the site of action, so that we can minimize the systemic effects from the medication, okay? All right, the next one we'll talk about is the long-acting beta agonist, the LABAs. Effects are longer lasting. An example of that is Ceravent, Cimeterol. If you're using an MDI, you want to shake well. This would not be used for someone that is having an onset of an asthma attack, okay? It's not going to fix the worsening wheezing or the bronchial constriction that's happening, okay? Action is much slower, but it has a longer duration of working, and the important thing is it takes a while to get a like a therapeutic level in the system to prevent asthma attacks from happening, okay? Usually 2 inhalations every 12 hours. Again, has a bronchodilation effect by relaxing bronchial smooth muscles, and as I said, a slow onset of action. Okay, and those are to be used, you know, whether or not a person is having symptoms, but they're to be taken all the time, even when a person is doing very, very well. Okay. The next group is the cholinergic antagonist. These actually block the parasympathetic nervous system, resulting in increased bronchial dilatation and decreased pulmonary secretions. Okay. These are also called anticholinergic drugs, very similar to the way atropine works. We give atropine for patients that have bradycardia or low heart rates. It doesn't work as well as a SABA, a short-acting beta agonist, but it can be used in place of a SABA for those that can't tolerate the side effects of the beta-2 agonist. Okay, an example of these would be Atrovert, and these are to be used several times a day, but one called Spiriva we use once a day. They work okay, but they do not work as effective as a beta-2 agonist. Okay. And remember too that they inhibit the parasympathetic nervous system, allowing the sympathetic nervous system to dominate, releasing norepinephrine that activates beta-2 receptors, and the purpose to relieve and prevent asthma. The one thing that we teach our patients when they're on these types of meds is to drink plenty of fluids, because the drugs can cause a lot of mouth dryness. Observe for blurred vision, eye pain, headache, signs of sympathetic overdose. Sometimes they get real shaky and they have a lot of difficulty trying to sleep at night. Okay, so that's your cholinergic antagonist. Okay, can be used in place of your SABAs if your patients do not tolerate the SABAs very well, but it doesn't work as effectively. All right, the next group of medications are your methylxanthines. And these are used when other types of management are ineffective. They're given systemically, but they may have many side effects. And some of the forms of methylxanthine are Theodore, which is an oral form, theophylline, aminophylline. They act like caffeine to cause bronchial dilatation by actually relaxing smooth muscle. There's used to prevent asthma attacks and to stop an attack once it has started. This might be a very aggressive way to prevent a very progressive asthma attack where the patient has really not gotten any response or relief from their SABA. So they're progressively getting worse. They might come into the emergency room and they might hang on an IV of methylxanthine like aminophylline. The big side effect from methylxanthines is high heart rate. It just causes a lot of stimulation. So we really have to watch for some of the severe side effects that occur, because remember, this medication will be taken into the body systemically. Okay. And again, if we have known that the patient has been on a type of theophylline prior to admission, we would definitely want to get some kind of theophylline level on the patient. Usually the therapeutic range is about 10 to 20, okay? If the patient would go home on a oral dose of Theodore, we would be sure that the patient comes on occasion for frequent blood checks of their theophylline levels. And one thing we would teach them is not to drink a lot of excessive coffee or other caffeinated beverages while on this drug, because it could exacerbate the effects. The drug is eliminated very slowly from the body. So that's why we would really do some dietary teaching on these patients who are on some type of methylxanthines when they go home. This is the kind of drug that We don't put every asthmatic on because we're always concerned about the systemic effects. Maybe they're not really getting good response from their long acting beta agonist, or maybe and so this might be an alternative, but we only want to use this if it's absolutely necessary, because this is a drug that has to be given systemically, and with systemic drugs we always risk the chance of some kind of side effect occurring. All right, and then another group of medication are your corticosteroids, because those meds that we just talked about have to do with the bronchoconstriction. Remember, we have two problems that are occurring. We have bronchoconstriction, bronchospasms, and then we have the inflammatory process. So those meds that I just talked about help to open up those airways, help with bronchodilation. So now we have to look at the anti-inflammatory agents. And obviously corticosteroids fall into that group of medications. We can either give inhaled or oral form, okay? We would use this anti-inflammatory drugs daily, even with no symptoms. Be sure that with inhalers the patient has good mouth care, correct technique. We wouldn't use that with, we wouldn't tell a patient to use it with the onset of their asthma symptoms or with any worsening of their wheezing. And remember too that with corticosteroids, okay, these are like I said, can be either given inhaled or oral form. And this just takes care of the inflammatory response of the mucous membranes in the airways. So it will not affect any type of bronchodilation. Usually with corticosteroid inhalers, such as Flovent or fluticasone, you would give 2 times a day. And again, check oral mouth for lesions or drainage or any type of lesions in the mouth. Again, the drug onset is slow, so that's why it would not be used for any type of a rescue drug if a patient was having an acute attack. Some of the oral forms of corticosteroids are like prednisone, deltazone. They're not used unless the asthma attack cannot be well controlled with any other therapies. Because remember, with long-term corticosteroid use, patients can develop GI ulcerations, really kind of develop some type of a Cushing's, which we'll get into with endocrine, weight gain, maybe that moon face that you've seen, and hyperglycemia. If your patients are already diabetic, this may definitely affect their blood glucose and may have to readjust their insulin or their medications that they're on. It's always important to take oral corticosteroids with food and not to suddenly stop taking these if you've been on them for long term, because your adrenal glands already produce cortisol, and when you're taking an outside source of corticosteroids, your adrenals do not secrete that hormone, so it will not have time for your own adrenals to secrete your own body's cortisol, so you could end up in some type of a crisis. So never abruptly stop taking corticosteroids, okay? The next one are your leukotriene antagonists. Again, not to be used as a rescue drug. This is Singular, or Montelukast is the generic name. Usually this is given about 10 milligrams every day PO. It blocks the leukotriene receptors, preventing the inflammatory mediator from stimulating inflammation. Remember when I talked about those mediators that cause that inflammatory response to occur? Well, this will kind of block that response from happening. And Singular, you know, you might have seen it or seen it prescribed for people that have allergies, okay? Your immunodulators, monoclonal antibodies that prevent allergens from binding receptor sites. An example of that would be Zolar, helps prevent the acute asthma attack, but not useful during an attack. This is a medication that is given sub-Q. Usually it's given every 2 to 3 weeks, given in the doctor's office, because you can see a possible anaphylaxis reaction. So they give it in the doctor's office, have the patient wait there for a little bit to make sure the patients tolerate the medication pretty good. Okay. Some of your other medications that might be given, your NSAIDs. I'm sorry, I skipped that one. Like your Chromone, that can either be both inhaled and oral. Tolade might be a kind of an inhaled medication, stabilizes the membranes of the mast cells and prevents the release of those inflammatory mediators. So another type of drug classification in which we can prevent or reduce that inflammatory process that occurs in the bronchioles. And that pretty much really is the most frequent type of categories of medication that we use for asthma. Remember when we talk about the inhalers, the DPIs, those are dry powdered inhalers. Those actually show on the inhaler the amount of remaining drug. Your aerosol inhalers do not, your MDIs, and to determine how much medication is left in them, you may want to place them in water, and a full inhaler will sink to the bottom, obviously, because there's medication in it. Empty floats on its side, and so that's why you have to encourage people and teach people that when they have the MDIs to count the doses as you use them, okay? These should be used with a spacer and to connect it correctly, to shake the medication, put in the mouthpiece with a good seal, breathe in slowly and deeply, and if it whistles, then you're breathing in too rapidly. Remove the mouthpiece, hold your breath for 10 seconds, breathe out slowly, and then you wait at least a minute between puffs, replace the cap, and clean at least once a day. And those might be encouraged to use, like I said before, any type of vigorous activity, exercise, or even sometimes before eating. Anything that's going to use up, oxygen or put a little bit more demand on the respiratory system. Other treatments for asthma is exercise and activity is recommended to promote ventilation and perfusion. Remember, oxygen is another one of the most important therapies that we give to patients, sometimes per mask, nasal cannula, or if it's a very severe, such as an status asthmaticus, an endotracheal tube. And even Helix can improve oxygen therapy. Kind of provides a better oxygenation with our patients, okay? And then lastly, just want to talk about status asthmaticus. This is a very serious situation. It's a severe, life-threatening, acute episode of airway obstruction that intensifies once it begins and often does not respond to the common therapy. So prior to this, many patients have had an asthma attack and then used their rescue inhaler, and it responded very nicely. Opened up the airways and they were fine. But this time now, something has really triggered a profound attack, which is not showing any evidence of good response. So this is progressively getting worse. And if the condition is not reversed, the patient may develop pneumothorax and cardiac or respiratory arrest. And so what happens is it just keeps getting progressively worse. Severe bronchospasms. Patients start to
use their accessory muscles, wheezing, labored breathing, even see distension of the neck veins, and sometimes the only thing to properly ventilate this patient is to intubate or maybe possibly do a tracheostomy on it. And with that distension of neck veins, this is when your patient may develop a pneumothorax or even lead to some kind of cardiac or respiratory arrest. And what you really want to watch for is when the patient comes in, obviously in the beginning of their attack, they're going to be breathing very fast, very rapid, be in a lot of distress. But over time, they're not going to be able to keep up that incredible amount of effort used to breathe. So when their breathing pattern starts to slow down, that's pretty evident that it's leading to somebody developing a respiratory arrest. These are the things that we will treat with a status asthmaticus episode. Bronchodilators, steroids, epinephrine, and oxygen. That's why it's very concerning when you're assessing their breath sounds and they become very decreased or absent. That's a sign that respiratory failure is imminent. Okay. So this is pretty much status asthmaticus, and really kind of encompasses what asthma is about and how we treat it and how important patient education is. All right. So I'll stop right here, and your next lecture will begin emphysema and chronic bronchitis.